Welcome, welcome to the USCB podcast. We're the podcast for health professionals and the wider community, looking at sport diverse ideas in health, ask some hard questions, and have some honest conversations. My name is Archie. I'm an EP based on Sydney's Northern Beaches, and joining me as always is allied health business owner Andrew. Andrew, how are you today?
I'm very well, Archie. How are you going?
I'm pretty well. I just realised my lung capacity is a little lower than it normally is. So I had a bit of a cold over the weekend, which as a result means I am drinking waters today. So I'm sorry to disappoint everyone there. And by everyone, I mean we have an EP guest, Matthew Wall, the bearded EP. Sorry, the mind, the mind and body EP. Welcome to the EP domination. Honest EP podcast, mate.
Mate, thanks for the invite. It's good to be here. Thank you.
It's good to have you. First off, what are you guys drinking, if anything?
Oh, I picked up, I couldn't get something from Ipswich, but I found a brew from Brizzy. It's new. It's an IPA, 62%. So it's a hazy IPA, I believe. So it'll be interesting to see how it goes.
Six point what percent? 6.2%?
Mm-hmm.
Oh, geez. Okay. All right. We'll hold the tough questions for the second half of the podcast, perhaps. Oh, dear.
It's just fun. It'll be fun.
What's the brewery called?
Range Brewery.
Range Brewery. Lovely. Beauty. Andrew, what have you got today, mate?
I have a glass of rosé today. I feel quite civilized.
You cultured man. Look, this might be the first time that we've had 3 different drinks on the same podcast. So there's a first in our many-yeared history of podcasting, Andrew. Yes, I'm on waters today.
What are we up to in terms of duration on this thing, Archie?
So we started August 2021, but I'm pretty sure we're up to episode 54.
Wowzers.
Which feels pretty wild. I don't know how many or how often we were trying to record them in the start, but we've definitely fluctuated in terms of our regularity of releasing podcasts. Matt, have you you messaged me on our podcast DM, so obviously listened to at least one of them.
Yes.
Only that one. Okay, good. All right, good. Well, don't go back to the start because the audio quality's trash. And not that this is that much better, but we'll hopefully a little bit better. Well, Matt, we started chatting over what's that thing called? Instagram, and we thought it'd be really interesting for you to come on the podcast. So why don't you start by telling us about your EP journey, mate?
Yeah, thanks for that. So when I started my EP journey, 7-8 years ago now. So it's been a few years around the sun, working in this profession, which loving so far and growing each day. So, but I started out in private practice land, working with a really awesome company, just a small kind of multidisciplinary kind of EP clinic in North Brisbane. And that was like one of my, that classic, you go to your clinical placements and you might get a job out of it. And that was one of those things. And so it was a really nice, smooth transition into the workforce because of that as well. Because it wasn't going into somewhere I didn't know. And I kind of knew the people, I knew how things worked. And so it was a nice, smooth transition from there as well. I started out 2 days a week in that job and slowly built up those hours and those times over those next few years. And that's sincere as well. So that was going for a while. Do a bit of tutoring as well on the side, as what many EPs do, which teaching is a big passion of mine. And then about 2 years into working, it was like started to get really interested in terms of the mental health side of things and how, I guess, how EPs can work in that space a lot more, but also, I guess, I felt that as EPs in our bachelor training, wasn't just hitting the mark for me when it comes to feeling confident, both in my communication skills, but also my knowledge and understanding around, I guess, the how physical health and mental health affect each other, how does exercise affect mental health, but also, how people perceive their bodies and their experience with movements and different things as well. And so went back and did some more study after that. So I did my 2 years of postgraduate mental health and psychotherapy training,
Wow.
uh, which was a big gig. Still working, four days full time over that time. And so, yeah, I'm a person that naturally can't say no to things.
I know one of those. I'm looking at
And,
him right now.
it's great when it comes to productivity, but, I don't help myself when it comes to my stress levels. I'll just say that.
It's just, I
Welcome.
feel like
Come
I feel like I am I
on.
looking at two of the same people in the room at the moment. Bloody hell. Go on, this is great. Oh.
Hey, I'm glad I'm not alone in that bus. And so it's a fun bus, but a challenging one. But where were we? Yeah. So I started my master's, kept working during that time, and it's really nice, I guess, learning all those new skills, new information, but also working at the same time, to kind of have that bit more context, a bit more experience under your belt. It was a very different learning experience compared to, undergrad, fresh out of school, kind of lacking much life experience in general. But to then apply those new things, was really, really helpful to my learning journey in that sense there as well. But also exploring, I guess, as that went on, as like where does this, I guess, how do we best utilize, brief interventions or different types of psychotherapy approaches within EP practice? Not as I'm practicing as a therapist, but more about how do we take those little things that are helpful in those situations, the more common factors across all different types of approaches. And as EPs, how can we utilize that as well? So whether that's more, I guess, how do we build effective therapeutic alliances? Or how do we work in a trauma-informed way? Or how do we, I guess, as EPs, which in my opinion, we're behavioral therapists because we work with exercise, and that's a behavior. We work with supporting people to change lifestyle behaviors. And that's a really difficult, challenging space to work in, both from our lens, but also the people that we're supporting to work with as well. And so this, I guess, curiosity of mine grew over time and explore, I guess, what are those influences on behavior? And as an EP, how can I be a bit, I guess, better aware of and better confident in navigating those barriers and the mitigating factors of behavior change, whether it be exercise or whether it be supporting someone to drink more water in a day or sleep a little bit better that day. Those small things can go a long way. But yeah, as I was doing, almost finished my master's, I got a part-time role in the community mental health services here in South Brisbane. That was a couple of days a week and job sharing that role with another really awesome EP. And so that we kind of serviced all different communities, public community mental health teams in that area in South Brisbane. We had a small little office gym, they're not much bigger than this room I'm in right now. But we're able to do so much out of that and work with people from, really young adults all the way to older adults, across the full mental health diagnostic kind of spectrum. But we also really worked a lot in is that kind of physical health space in that because a lot of that's missing in the mental health services. It was missing and it's now getting better, getting integrated with. And so we brought, I guess, not just more, I guess, supportive therapies for mental health, but also we addressed a lot of the physical health issues that people were experiencing as well. And that's in CO2. So, yeah, so I was in that role for a little while. And then the role that I currently sit in started off, I guess, early last year in January. And that was a full-time role in an acute mental health inpatient unit. So that's all up, it's 72 beds, including a hospital and the home service. So there's just myself. Well, now I have a new grad under me, which is awesome. But
Oh wow.
that's a whole nother story, which is really cool.
Yeah.
But for a whole last year, it was just myself, managing the gym, managing the EP service, and working in that kind of multidisciplinary team model, in an inpatient model, in inpatient care. And so that's where I am now today. So yeah,
Wow. That is a incredibly varied and well, you've had so many wild experiences, Matt, in what feels like actually a short amount of time. I've been taking a lot of mental notes about what you've been saying there because there's some topics I really, really want to hit. One off the bat is big when you're talking about kind of EPs working in with more of a trauma informed or psychotherapy informed or psychologically informed practice. Um, I know that one of the things that especially younger EPs or newer EPs run into all the time is going, oh, what's my scope? It's like, what am I allowed to touch here and what am I not allowed to touch here? It's like, oh, when am I being too much of a therapist and when am I just active listening, or, just helping with behavior change? And people get really nervous and really unsure about what they're doing and if they're doing what they're doing is still being an EP or if they're crossing any boundaries. Did you experience that?
Yeah, absolutely. It's amazing what people will tell you when you're walking on a treadmill with them, you know? You're sitting there having a chat, checking in. And there's something about, I guess, our approach, but also the impact of exercise to make people feel more comfortable in sharing as well. So it's, regulating for our brain, it's regulating for our fight or flight systems
Mm,
that often make us avoid those conversations.
mm,
And so when we're, I guess, if people are sharing with you those things, that means you've created the environment that's safe enough for them to connect that way.
mm,
And it's not that's not just for mental health clinicians to do that, but that's across the full healthcare profession range.
mm,
If clients are doing that for you, I mean you've done the hard work to
mm,
make that person feel safe.
mm,
To develop a connection, and that person felt, okay, this person's actually going to listen to me.
mm,
Uh, and so, because, not being heard and feeling unheard or feeling invalidated is a very common experience in the mental health kind of space.
mm,
And so I think, it's good to kind of keep that in mind, that where is my limit? Like, where is my scope?
mm,
And as well. And there's no harm in that person sharing things with you
for
um,
sure.
there as well. And so it's, but that active listening, that connection of, hey, I'm really glad you shared that with me. That sounds like
Mm,
a really tough thing. Have you talked to anyone about that yet?
mm,
Right?
mm,
Sometimes we can be that person just to take note, to listen, to kind of connect that person with the person that's best placed to carry that conversation onwards.
mm, mm,
I remember a younger client, my probably second year out, she came in crying. She was distressed. And she was feeling suicidal. And to have that conversation as a younger clinician was daunting, to be honest.
mm,
The
mm.
thought at the top of my mind is, what if I say something wrong? you know?
Yeah, absolutely.
And so, but the important thing is, if you keep it to, I guess, from our plan's point of view, is what are they saying to you? How are they feeling? How do we validate what they're feeling? How do we show empathy towards their experience?
Mm,
Uh, so it's not our role to change anything in that. But if we make people feel heard, feel supported, and those really kind of uncomfortable conversations, then that can actually make people feel more, I guess, confident in making changes, wherever that's going to see a GP, see a psychologist, see a therapist. But sometimes we're just those people who've made that first contact
mm,
and lead them on, but also equip them with, exercise is a great distress tolerance skill, whether we're feeling overwhelmed or whether it's just, hey, right now there's a lot going on. What are those kind of key routines in your day that you think are really important that we should be keeping up, amongst everything that's going on right now for you?
mm,
Whether that's your sleep, whether that's your food, whether that's your movements or
mm.
social. Those are all within our kind of realm to explore with people in that space.
Matt, you're spitting fire right now, mate. Jesus Christ, would you be writing? I hope someone's recording this. Oh, wait, far out. Because I was going to ask so many follow-up questions, but you answered all of my follow-up questions as you were talking. I don't know, Andrew, did any of that resonate with you?
Oh, it all resonated with me. I think you're right. That's fantastic. The question that I have is, and because we know that a few of our audience here are new or recent graduates, what do the newer EPs need to know about working with people in mental health? Like, what if you could summarize all of your knowledge down into a few key points? Like, what would be your key takeaways for that people that potentially, haven't been exposed to your sort of environment?
Yeah. When I was learning my masters, there was a lot of crossovers in, I guess, how we approach chronic pain or pain care, and the language we use and the approach we use when it comes to how we approach mental health as well. So it might be they have a diagnosis of, say, generalized anxiety disorder, for example. That only tells us so much. It's a classification, right? And so, just like we would ask around with pain, like, how does this impact you? What is this stopping you from engaging in? What is that impact of it? And exploring that with them. So, hey, if you do see that generalized anxiety disorder on the referral list, say, hey, part of our care is to kind of work with your physical health and your mental health at the same time. Would it be okay if I asked a question around your anxiety and how it affects you? To ask that permission, and if they say yes, they're inviting you to a kind of explore that within the context of which you're working with them as well. That's there as well. So explore the impact, or sometimes I can question, say, hey, how's anxiety affected your, I guess, ability to participate in exercise in the past? Do you feel your heart races a lot of the time? And sometimes that can make exercise quite uncomfortable because, rather than starting at 60 beats per minute, you're starting at 120 beats per minute. You're already losing that, I
Yeah.
guess, physiological capacity in that sense there as well. And so explore the impact of their, I guess, mental health experiences, and then also how does it impact their ability to engage in those kind of, I guess, positive, helpful behaviors, whether that be
Mm.
exercise or something like else, something different there as well. So, you know, I saw a lot of crossovers between that pain, how we talk about pain and explore exercise and pain, and then how do we explore exercise and how we talk about it with mental health as
Interesting. So talking about it more as like, how is it being a barrier to you doing these positive health behaviors that we talk about with this person anyway?
well. Because it
Nice.
can be a barrier. It
Mm.
can be, a small thing can feel overwhelming to them. The thought of exercising, or sometimes we don't do well when it comes to communicating around exercise. We keep telling people just go for a walk, but
Mm.
they're down in the dumps or they're feeling overwhelmed. Like just getting told what to do can make us feel more overwhelmed.
Mm. Mm.
So without that validation, without that connection, without that also reality check of, hey, even doing these small things can be really hard.
Mm.
How do we, I guess, adjust our expectations? How do we adjust our exercises to meet us where we're at on that given day? You know, and so we think exercise needs to be a structured thing or progressive thing. You know, over the week we might get it to a progression point, but we've changed it 10 times whether it comes to the intensity or the duration, or we've rested a particular day because everything else in our life was just a bit too much. And that's okay, to kind of model that flexibility in how we use exercise
Mm.
in terms of how we feel. Because if we're a bit too rigid, which a lot of us are, we can feel quite bad about not exercising enough or
Mm.
not
Mm.
doing the planned session that my exercise physiologist gave me.
Right.
Because there's other things in my life that are making that particular thing just a bit too overwhelming.
Mm. Mm. So you don't want people to feel any guilt around uh, the exercise side of it, right? Mm.
When you say, hey, after exercise and starting something new, we can get more sensitive in how our pain experience, right? And the same thing for kind of depression and anxiety, for example, you're starting something off, it's going to be hard.
Mm. Mm. Yeah.
In that sense there too. And, those starting those new habits, starting those new behaviors. And that's why sometimes the little things go a lot more longer way initially
Mm.
in the beginning versus starting with the perfect gold standard evidence-based program.
Mm.
Just starting off with just how do we get this person moving within their occupation and what they're doing,
Mm.
where they're at,
Mm.
and so those early positive experiences in them achieving it, no
Mm.
matter how big, no matter so small, but also then allowing that mindfulness around how do they benefit from that
Mm.
in the
Mm.
moment, or I guess in hindsight, how do they benefit in the longer run too?
Wow. It's interesting, Matt, the way you're talking about it, and you did say that it's similar to how we talk about people with persistent pain or chronic pain. Um, but it really sounds like to me, and this is probably helpful for people who are seeing people with mental health, is that you're not really treating it like anything that's different to another condition that people would come in with, or another barrier to exercise, or another injury. But I feel like we're internally nervous when you see somebody that says anxiety or depression or a mental health condition, and we panic because we go, I don't feel like I have the training or the ability to help this person. When the way you're talking about it, you make it sound so simple and so straightforward, and that it's really similar to how we would approach someone coming in with a lot of other complaints or a lot of other like goals.
Yeah, and lean on your client's lived experience. So, what is their experience with their anxiety? What is their experience with their schizophrenia?
Mm,
Because no matter what the textbook will tell us, there's such a variation, I think a larger variation in how people experience mental health than say how they experience hypertension.
mm, for
I
sure.
mean, there's much research, there's much learning about a particular diagnosis, but their lived experience is sometimes the most important telltale signs in what support they need and where they're struggling the most, and how can we support them as well. In that sense there as well. And at the same time, remembering we're human too. You know, we're not, avoid from experiencing challenging mental health challenges. My thesis was in the mental health of EPs. In a cross-sectional survey across Australia, 44% of reporting have a mental health diagnosis.
Wow.
That's almost one in two.
Wow.
Albeit a small cross-section, but still telling, nevertheless.
Mm,
And so sometimes we're not just, I guess, nervous about the person we're working with. Sometimes we're also nervous about our own situation as well, and how, I guess, sometimes it can feel more real because it might be similar to something that we've experienced ourselves.
mm. Wow. That is very deep. Very, very deep. Andrew, I I know you're probably relating a lot to some of Matt's experiences here because you previously did a lot of work with the mental health space as well. Do you remember when you first started working in this area and some of the challenges or the feelings that you had as an EP working in the space and how you dealt with those?
I 100% agree with that, that it can be very nerve-wracking or confronting, or when you see a mental health diagnosis on a Medicare referral, it's like, oh no, I shouldn't talk about that. That's for a psychologist or that's for a counselor. Like that bit there is not for me. Um, but like to Matt's point, which was so well articulated, like people that have experienced the vast majority of people that have experienced a mental health condition almost like see it as part of themselves. And so they're actually the best person to ask about it because their own experience in going through that has shaped who they are and the way that they're showing up to you now. And it's quite remiss of us to not include those conversations about, oh, I see on your referral you've also, it says that there's a diagnosis of this thing. Is it okay if I ask you a couple of questions about that? My experience has been that 99% of people say, yeah, sure. Like, what do you want to know? Because they're very aware of how that's shown up for them. And like Matt said, there's a great opportunity then to understand how can we best support people in doing exercise, knowing that about them, because that might need to change. Like the way that we educate or the way that we try and motivate and encourage people might need to change based on they might not have pain, but they might have a general anxiety disorder. They might have schizophrenia. And so our ability to understand what has prevented people in the past from adapting a more active lifestyle will enable us to have a better conversation with them. I think you articulated that so well, Matt. That was really good.
Yeah, and from a physical activity point of view, what we now know from research is that anything helps. It doesn't have to be 150 minutes a week. It doesn't have to be strength twice a week. moving our body, and I find changing the language from, I guess, exercise to how do we just engage in movement that makes us feel well, that makes us feel strong, that makes us feel energetic. When we use that kind of language too, it's a lot more inviting, and it also challenges a lot of, I guess, the preconceptions that someone can have around exercise. For example, I work in a gym inside a mental health and patient unit. You would think that a lot of people would be quite avoidant or quite permissive of that. But it's one of the most used services within the entire hospital, because it's how do we support people to engage in movement that one makes them feel good in the moment, but actually benefits them to kind of feel more confident in engaging in their mental health kind of experiences as well. And that self-efficacy building and that mastery and the autonomy, that's what drives the motivation building too.
Mm.
Sometimes I think we rely on motivation too much, and I call it a bit of a trap because if we wait for motivation, nothing gets done. Especially when we're experiencing low mood, which amotivation is so common in that kind of space. And so if we're not, if the question is, rather than waiting for motivation, how do we be flexible? How do we adjust? How do we adapt what we think we need to do to meet us where we're at within what we think is achievable for that moment, not tomorrow, but just where we are right now. And so that we can do those things and consistently, but it might be at different amounts or different intensities. And that's perfectly okay. And so it just builds that flexibility in how we respond to not just what we're doing, but how we're feeling as well.
One of the things that I learned quickly in working with people with mental health conditions is like the 12-week exercise prescription that I wrote out that was like this is the best plan in the world and every like that just got thrown out the door like very, very quickly. And for a lot of people, celebrating the fact that they actually just turned up when they were supposed to turn up. And, I might have had a plan, but how they presented that day was like, okay, we're not doing that thing because that's not going to suit you right now. We might just go for a walk today. Or we might just go and, sit and we can have a chat in the sunshine or do something. I think that was the biggest key for me is like the whole idea of having a rigid structure about, like you said, progressively overloading people over a period of time. That just got put in the bin really quickly because people's mood was very up and down.
Yeah. And we're not adapting, I guess, the exercise variabilities a lot of much. We're more adapting the behavior of exercise in modeling that to the person we're working with to say, hey, it's okay to change what we do based on how we feel. What matters is how do we support that person to keep engaging in amongst feeling not great. And so also kind of models that acceptance of, hey, in life, there's going to be times that we're going to feel pain, right? We can't always avoid pain too, because when we avoid pain, we're also avoiding all the good things in life as well. And so how do we work with pain, whether that be physical, emotional, psychological, social, whatever that might be? How do we work with it? What do we need to adapt so we can keep doing the things that are meaningful to us, the things that keep us connected to, I guess, our values or what we find enjoyable, or our family and friends, or whatever that might be. But also, that validation around we're all human. We're natural avoiders. We avoid everything. You know, I always like to use the analogy like electricity. Electricity always follows a path of least resistance
Hmm. Nice.
at all times. And, I feel like as humans, we're like that as well, unless
Mm.
we're aware of it to kind of go, hey, if I can't keep following this direction, it's pulling me away from the things that actually keeping me hopeful or keeping
Mm.
me engaged or my occupation or my enjoyment in what I do as well.
Mm. That's something on what you're talking about around like a motivation and people when they are in a period of low mood. And what was coming into my head is, people who often have a PT background or an exercise background, accountability is such an important thing. And going, oh, I, I am here as the balloons come across the Zoom screen because I did a peace sign or something. um, uh, that I'm here to provide accountability to my clients, so I have to make sure they stay on the right path. But then also there's that opposing view of, well, no, we have to listen to our bodies as well. Um, and when, one side of us is saying, well, we have to keep this person accountable. And we've also say with a lot of things that we should listen to your body, and your body's saying, don't do much right now. It's like, where do you feel like you need to sit as this person's EP in that situation?
And so, in my mind, you know, where I am is where the patient, where the client is. That's my position. It's neither this or that. A lot of the times, in my experience, I think the patient is more rigid and more critical than I am.
Mm, mm,
That might be just the nature of how I practice, but um, you know, explore supporting the person to be able to be aware of the factors that are affecting them and the factors that are, I guess, making things feel more difficult, more challenging. You know, RPE changes so rapidly, you
mm,
know,
mm,
and an exercise today can feel much harder tomorrow just because we haven't slept well that night.
mm, mm,
And so, accountability of behavior, sure. It's more about accountability of how do we adapt to basically the things we do, And so, because if we don't adapt, we only get more frustrated. We become more inflexible, and we actually become more disengaged from what we're doing as well.
mm,
And so that's where a lot of the times where that, you know, you hear the theory if you don't do that activity for 2 days in a row, then you don't do it again kind of thing,
mm,
right?
mm,
A lot of that is just the doing part. There's no, I guess, exploration of the actual being part and what is actually influencing that behavior or not. And so that's really my position. It's neither this or that. It's not, I guess, again, if we're modeling a very rigid sense, the clients are going to pick up that really quick.
mm,
They're going to become rigid too. So
mm,
when they come to a point where they need to adjust, if they know is all or nothing or rigid kind of, I guess, strategies,
mm. Yeah,
it's going to be a situation where that's not going to work well.
absolutely.
So, and from a exercise outcome point of view, or from a mental health point of view as well.
Mm. So we've got to be kind of less rigid with our rules, and and I like what you're saying there around just being where the person is rather than you're on this side of them or you're on the other side of them, trying to pull them in a direction. It's like, no, you're just where they are. That's a
Yeah,
really interesting way to think about it. I like that.
they have to choose the direction. We can't change people; they have to change themselves. But how do we support them to make that change that's meaningful to them is the question in hand.
Mm,
And so we don't they whatever we can do to support that person to make that choice to engage or adapt, that's the self-efficacy. That's the
mm,
I did this kind of thing. When clients say to us, oh, thanks, you've done so much for me, you've done all this. And I always, I'm like, hey, I really appreciate that. But you've done the work. You've adapted, you've gone through all this stuff. People recovering from suicide and different things I work with. But here they are, engaging in exercise, working with how they feel, working with the grief, working with the stress, the anxiety. But
mm,
here they are working with it. And that
mm.
to me is a lot harder and a lot more, I guess, admirable than my position of being on the other end. And that's there as well.
Wow. Holy moly. Andrew, do you have any questions or thoughts on some of that stuff that Matt said? Otherwise, I have a question in a bit of a different direction.
No, you divert us.
So it's not a huge diversion. It's back to something you were saying very early on. But when you do end up in these conversations where someone feels comfortable and they feel safe with you to talk about how they're feeling, and they're opening up to you, and we've done a good job in this situation of like making them feel heard and validating their feelings and what they're going through. How do you know when you've you've kind of talked about it enough, if that makes sense? So how do you know? Because you were also saying that there's a point where you can go, it's like, well, do you want to use some strategies, or what strategies can you use to that are achievable for you at the moment? But how do you know when you've gone through enough of what they're talking about, or they feel like they've covered enough of what they're talking about for you to then talk about it in a way of, well, let's do something? Because I know my own brain, not my clinician brain, but just my Archie brain is very solutions based, and I know that in this situation, not helpful to jump to solutions. Very not helpful. And I get in trouble for that at home all the time. So it's something I'm working on. But how do you know? How do you know when you go, okay, now it's time to talk about solutions?
I think it's hard to do it, but you got to be get comfortable in just acknowledging what's happening in the room to kind of go, hey, I'm really glad you told me that. We've talked about this for a little bit. We've talked about some strategies about what we can do right now, or what you feel you can do right now. And that's there as well. How can what in doing that, what can we do right now? Kind of thing there as well. Not just in a talking sense. We can keep talking about this, but what do you think we can do from a movement perspective right now? Or
Mm,
can I help you to call someone to talk about it? So sometimes we can be that support person in the room, just
mm,
someone to make a call. And so I think it's that kind of just acknowledging of where we're at in the room. I know many times of, hey, I feel pretty stuck in how we're working together right now. Do you feel stuck as well? And they're like, yeah, I do. I feel stuck. I'm like, cool. How do we work this out together?
mm,
Because I feel like we're here, we're getting stuck in this kind of moment, but we're not moving forwards right now. And so it's more than okay to acknowledge about where we're at, what we're noticing, but also asking, like, is that your experience too? To kind of acknowledge that our experience is different to their experience a lot of the time. And so, but if we're feeling a little bit, I guess, stuck, I guarantee it, that person's feeling a bit stuck themselves.
mm,
And that's sincere as well. And so, yeah, again, that invitation, the exploration, the acknowledgement
mm,
um, can go a long way. And it may not lead to any type of exercise at a session. They might go, hey, do you feel like we need to call there
mm,
today? And that's there as well because you know people need to recover even after talking about the stress things, just like we recover after exercise. It's a
mm,
form of stress on the body, and
mm.
they still need to recover. So sometimes exercise isn't the most helpful thing to that situation, and that's okay. Doesn't mean we can't help. There's many other ways we help people than just exercising people. But there's many times I've terminated exercise sessions because it just wasn't going to be helpful. It was just adding more stress into the cup, which is already overflowing with stress.
Mm. Yeah, nice.
Yeah.
One of the things that came to me as you were talking then, Matt, was, and it's certainly something that I know that I've done in the past, was I wasn't willing to have that conversation with people. That
Mm,
when, I might have been seeing this person for a little while and I feel like we've been kind of going around and around in circles and it doesn't seem like we're making much progress. Um, and so, and what I can see in other, not just EPs, but other allied health professionals as well, is like when we're not seeing progress, sometimes it can be a bit of a position where we just go, okay, I'm not the right person to help you. And so we sort of discharge people or we refer them on to somewhere else before we kind of have that conversation of like, you know, are you, like you said, like I'm feeling a bit stuck. Are you feeling this way as well? What do you think are some ways through this or some different ways that we can kind of for us to be able to work together to work towards some of the goals that you said? I find that sometimes it's just easier to just go, oh, I'm not the person to help you. How can we as EPs have that conversation safely? Like, is that a safe conversation to have with clients? Like, I don't know if I'm right for you. I don't know if you're right for me. Like, how can we do this?
yeah, it's certainly a conversation that can come up. Doesn't happen very often, right? I think as EPs, we're very adaptable people, very adaptable in our interventions. So there's only going to be very few people that we're just not going to gel with. We're not just going to, I guess, feel like we're helping them. In that sense there as well. And I think first acknowledging that and then go, hey, Is this a me feeling like I'm getting really close with my professional and personal identity, the feeling that I can't help someone? I hate that feeling of feeling I can't help someone. It drives me insane.
Mm.
I'm very similar to Archie in that kind of solution focus. My kind of in how I react to my emotions. I'm like, okay, what do I need to fix? What do I need to do? Tell me what to do. Kind of thing, right? And I have to catch myself all the time and go, no, that's me, not them. Because when we get stuck in our own space, it's being able to empathize and understand their space can become quite cloudy. And that's there as well. And that's where a lot of that anxiety comes from, having those conversations. And that's there too. And so a lot of the time, it's when you acknowledge that space of, hey, I'm feeling we're stuck here. Is this I'm really curious about your experiences in how, I guess, you've experienced my support. Because I feel like I can help in this areas, but I feel like I'm not helping in that sense there as well. And so that curiosity in their experience to kind of challenge my own, I guess, assumptions about what's happening. But also that I guess creating the space to discuss it in a really nice kind of I guess safe way. It doesn't accuse either party of any wrongdoing because we can feel bad that we're not helping something, but if I'm a person, if I can't do something for myself, I get frustrated. And so that's my own personal frustration with exercise because it's that similar kind of thing, right? If I don't do that, then I get frustrated. They might be in that same boat of going, I've been trying to do more exercise because, just been diagnosed with type 2 diabetes. I know it's important. I keep being told, but this is really difficult to fit around my job, my family, my life. And so a lot of the time, it's not us, but it's a mixture of factors from them, us, and everything else in between. And that sense there as well. We both have a responsibility in that kind of engagement, yes. Avoiding the conversation, again, is avoidance. But it's perfectly okay after that discussion to go, hey, this is where I'm sitting. I'm feeling like, I'm not the right practitioner for you, even after we discussed that. Would it be okay if I referred you on to a practitioner that would be more suited to you? Would that be okay? And to show that confidence in where you're at also is really appreciated on the other front, on the other side. And so because we're discussing it, we're acknowledging it, and acknowledging both experiences in it. And a lot of the time, whether they continue on with you or not, the fact that you're recognizing those things and discussing the barriers and experience of behavior change or exercise, that's only going to do them good moving forwards. And sometimes they need that conversation then to go continue working with someone else to kind of go, that's what they meant. And it doesn't always just have to be us. I think as EPs we're getting better, but what we do well is work together as a professional community to kind of go, hey, I've been referred this person for another EP. Absolutely, I'll take that person on. Learning from their experiences and then taking that on from there. I think we've come a long way in that way. In the public space, it's really a lot like that because there's that less competition nature. But even in the private field, I feel like even though we might be privately competing with other EP clinics, I think we're still very supportive and very advocating for each other, nonetheless.
I could definitely relate to that. And I'm not sure how it is in other professions, but I do feel like we are quite open and welcoming with other clinics, even in our private sector, that if someone feels like there's a EP with a better specialty in an area down the road, then I will happily talk to that EP about referring this person on, because I feel like the the vast majority of us are just out for the best for our clients, right?
We do what we do, right? And so
Absolutely.
when we work in community, we can only have good outcomes.
Hmm.
And so, in this Sarah that you heard in the podcast previously, who goes out to see different people in different clinics, even in
Yeah.
different states,
Awesome.
like how cool is that?
Hmm. Very, very cool. Nat, I want to ask you about your transition from private practice and obviously some stuff in between into the public sector. And and how did you find that change from going from a private clinic where there's money involved, just from a basic sense, and you book people in to working in a public hospital where people come to you and you don't talk about money at any point with them and all these other things. So what was that change like for you?
It's interesting. It's funny because I go to them a lot of the time because I knock on their doors and go, "Hey, remember me?" Kind of thing. Did we agreed on earlier in the day? Yep, it's that time. And so, yeah, it's it's a different experience. Yes, there's that, I guess, change in, I guess, expectation around money and business and that kind of stuff. That's, I guess, something personally I've worked with and struggled with a lot of the time. And I don't never put my, I guess, personal experiences onto anyone else. But coming to the public space, having that, I guess, less pressure on that side of things um, was really, really freeing, I guess, in my experience. But at the same time, the business kind of financial side of stuff gets replaced with service development work and service reviews and public health administration. And so there's a different thing that fills that space. And that's the there as well. But that at the same time, for me, is really exciting because that stuff also allows me to not just review what I'm doing and keeping up to date, but also advocate for the profession in the space as well. To kind of go, hey, here's a working model of an EP in the inpatient unit. Here's the data. Here's the so far referral data. Here's the outcomes data. Here's the feedback from patients themselves. And to then expand that across different other health services and mental health services is really cool. And so, but at the same time, the way I've set my service up, it kind of runs like a private practice, having bookings, having group classes, kind of where possible, people are, I guess, booking themselves in or writing themselves up for groups. But at the same time, in the area that I work, there's a lot more work from our end to kind of organize that stuff compared to clients, would do that quite normally in a private practice, to book up to make an appointment, go from there as well. But there's a lot more work on our end, I guess, on that front in the public space. But the autonomy, the freedom to, I guess, work as you want to work and be a practitioner. You want to be a practitioner. That's
Mm.
all. That's all the same. I thought initially coming in that it was going to be really rigid and very structured to kind of go, okay, we do this, then we do that, then we do this. Not the case. It might be in a little bit more kind of thing like cardiac rehab, where
Mm.
there's really strict kind of, really important structure
Yeah, sure.
to their rehabilitation plans and different things. But in the mental health space, there's so much, I guess, autonomy as a clinician to adapt the service itself, but also your practice itself for the person. And that's there as well. And so I think, yeah, I think as well, from a public perspective, there's a lot more, I think, complexity. I think there's a lot more, I guess, combination of different things. And I say that, I guess, from a bit more of a mental health perspective where
Mm.
it might be working with someone with, paranoid schizophrenia, but they also had a stroke 2 years ago. And so you're doing stroke rehab with them.
Mm. Mm.
And then also, part of that experience with that. And so there's a lot more, I guess, combination, and there's a lot more psychosocial stresses of people that often are accessing the public health services. And two, I feel like as EPs, I feel like I'm working way more to my scope limits than I was in private practice. And so, because there's a lot more complexity to kind of manage and to navigate and to communicate around,
Wow.
and as well. And so, as we think about, even just socioeconomic status as that one factor.
Mm.
Right?
Mm.
I think as EPs, we're quite accessible on that front, but we're still, in that finance barrier, and we should be paid for our work and those things there as well. But there's also the element of healthcare, and so how do we? And a lot of people that access that public healthcare, free public healthcare, or people that often can't afford it privately, and that's there as well. And to be able to give people the time they need, that is individual is fully to them without any expectation around the finance side of things is it's a different experience. I'm not saying one is good or bad. It's just a different way of working, basically. And so, but yeah,
Super interesting. What would you say? Because I know you have a lot of freedom, and when we're talking about that, the prescription for mental health can be anything and a lot of different volumes and intensities as well. Do you find you still have a bias of like what exercises you like?
you could say that. I think, I don't know. I like to keep it simple. Like at the same time, I don't mind like a complex program for a particular rehab thing or a particular complex program for a sport programming point of view. Like I love that stuff too as an EP. So I think all of us kind of do. But at the same time, I think I keep things really simple from organizing a circuit group. It's, two lower, two upper, two cardio, and
Keep it
I just
simple.
adapt whatever that option is to the person that's doing that particular station. So there might be four people doing that group class, but each station, they might do four different exercises at one station because they're all doing different things at different strength levels, at different kind of spaces. And so, or someone might stop halfway. And that's okay, and so you've got to work with what you go. I find that it's not the exercise itself, it's just more about how we frame it and how we, I guess, model mindfulness around why we're doing it, but also how we experience it as well. And so, like, I do a high intensity interval group, you know, rather than 30 minutes, 45 minutes, it's 10 minutes long, and so it's not designed to create the best fitness outcomes. It's designed to regulate, it's designed to get people moving in a way that they do it, but they don't feel fatigued or tired or, I guess, afterwards. Because a lot of the time, those more higher intensities, that's what people associate with it. It's like, oh, I'm going to feel like crap afterwards. Think about just leg day. Those two words have so much connotation to it. But how do we, I guess, create those positive experiences for each person in that front there as well? And so I guess I don't really have favorite exercises or that I'll use all the time, but my approach is the same for everyone, but the
Mm,
outcome is different for everyone, if that makes sense.
absolutely. Yeah.
Yeah.
Andrew, you're leaning forward.
Coaching. Uh, what in your story at the beginning, Matt, you were talking about multidisciplinary care. I'm really interested in the role that you have now. What does good multidisciplinary care look like
Good
for
multi,
people with mental
yeah,
health?
I think good multidisciplinary care at its best when the environment allows is interprofessional. So I love doing sessions together with the OTs. I love doing sessions together with the psychologist and having both of us, I guess, working together to, I guess, support a person where they're at. I think our scopes all complement each other, whether we're working separately with that person or together with that person. And that's the theory as well. And I think, that I guess sometimes as EPs, we need to go, hey, no, we have an important voice in this matter. Our voice is valuable in this manner, but from a physical health point of view, but also the mental health side of things as well, to advocate, to to I guess to I guess show that there's another way of looking at this challenge, and that's just there as well. So because there's things that clients tell me that they don't tell their psychiatrist, the challenges they experience and the wins. I think sometimes we focus so much on the losses or the weaknesses or the challenges that even in especially in patient care, where a lot of that is happening, we don't focus on the wins as much. And so during our weekly MDT case reviews, I'm always highlighting about what people are achieving, even amongst, if they're still acutely unwell or even amongst still feeling suicidal, what are they achieving? What are they engaging in? And so, because when we start to acknowledge that as a team, you know, that our team becomes reinforcers. And we also kind of have a shared message about what we're aiming to do. So the kind of strength-based focus. And so, but sometimes, I might be working with someone, so this is like Holt's BOT, same person. And we're all working from our scope and from what we're trying to achieve. But we all have a similar message that we're trying to get across. And a lot of the time, especially in, I guess, crisis kind of mental health kind of, like distress kind of spaces, one, we need to recognize what we feel, but the important thing is how we respond to how we feel. You know, how we do that as an EPs is, okay, let's move with our feelings. And from an OT perspective, I might go, hey, how do we recognize our senses and our sensory aspects in this here as well? From a psychologist perspective, we might go, how do we challenge those thoughts that we're having? But we're all going, okay, well, how do we respond to how we're feeling? But we're all doing different things, but the approach is the same. Good MDT, I think, is highlighting the common characteristic between each profession, but we're each working from our own different scope kind of lens. And that's there as well, because sometimes messaging can be inconsistent. One person tells me this, one person tells me that. And so when we're a bit more, I guess, working from each our own lens, but we're sharing the common factors, we're sharing the common kind of messaging, right? That goes a long way, especially in that kind of early stage recovery kind of thing.
Andrew, can you relate that to what you feel like good MDT could look like in private practice as well?
I love that. I think understanding, um, like we've said, we each have a scope of practice, but we're applying our scope of practice to the person that's in front of us. And so I think fundamentally there is a need for excellent communication about understanding in the lens that I am looking through, how can I best help this person, and how can I best support the other people in this multidisciplinary care circle for this individual to see what I'm seeing so that they can, because you're right, I do think there's this opportunity that exercise brings where conversation just tends to come up a little bit easier than sitting in a chair and being static for 45 or 60 minutes. I just feel like there's things that come up and there's points that can kind of relate to one another that we tend to get a bit of a finer lens on as EPs. And so I think good multidisciplinary care from our perspective then is to be able to have a platform to share that. And obviously, hopefully that the other people are as eager as we are to be able to help the person that's in front. But for me, and perhaps from perhaps more of a business or a private practice perspective, good multidisciplinary care is about communication. Because you can't care for somebody through different lenses if you're not communicating.
Exactly. I think early on to my role, especially coming to a new facility, a brand new service, EP as a service was brand new to the entire health district. And so not many people knew, I guess, how an EP works and how we support people. They knew what we are, but it's more how we work is, I guess, the unknown factor. Earlier on, I just focused on building relationships with different clinicians, with the nursing staff. From an inpatient perspective, if you get the nursing staff on your side, you can do anything. Anything is achievable. But it all starts back down as that relationship building. From not just walking to the nursing station going, okay, I'm doing this, I'm doing that, see you later. It's more, hey, how are you, Archie? How are you today? That recognition of each person, then the profession, can go a long way to helping, I guess, create little advocates, not just for yourself, but for everyone kind of down the track, And so I always invite different members of the different staffing, different professions along to my groups to go, hey, come and do this with me, kind of thing, right? Because when patients see that, I think that also go, hey, they're working together, they're collaborating. That's really cool. And then to get different perspectives. Even if it's from an EP and physio thing, I work closely with the physios from the main hospital and how we can better support people together versus this or that. It's how we can do this together. From a communication perspective, from an intervention perspective, how do we work together in this kind of manner? And so, yeah, that I guess that relationship building is so critical in that sense there as well.
I'm curious on when there are um, different professional perspectives on what best treatment looks like for an individual, because this comes up every now and again.
Hmm.
Um, from your perspective, what's the best way to kind of navigate that?
think
And
I'm always
yeah,
curious about because I might be aware of what I think something is, but we always talk in conclusive statements. This is good. This is bad. I'm more curious about why they think that way. And that's sincere as well. Not trying to, and when we invite that person to share why they're thinking, I'm like, hey, that makes a lot of sense actually, given the information they're working on, because we might be working off total different information sets. You know, it's similar to like, for example, like an AI tool. You give it two different instructions that for a particular outcome, it has two different outcomes, two different recommendation sets. And I think regardless of how closely we work together or how closely we might work in self building, um, I think we're still going to have two different information sets. And that's there as well. So I'm always, sometimes asking people, hey, how do you feel that person would engage with exercise before engagement? To gather that information, to explore about, okay, what do they already know that I don't? And that's there as well. Or how maybe it's not this or that, but how do we adapt this together? Because I think I have a good idea, you have a good idea. How do we conjoin these two together? I think there as well. And so that was something that, we were working with the physiotherapist in the hospital was really helpful because, hey, how do we align ourselves here? You're really great in the acute management in that kind of assessment space. That's your specialty. What do you need from me to support you to do that kind of thing? Is it information? Is it communication? So now I'm also like the communication point between the treatment team and the physiotherapists because they're a whole different buildings, whole different services. So just filling that one point of communication has improved outcomes for patients because they're engaging. And so I'm always curious about the other side. And I guess acknowledging what I don't know. And I think that's the uncomfortable thing to say. And to acknowledge is what we don't know. And that's sincere as well. And a lot of the time it's the reasoning, and not saying, oh, why do you think that? Give me a reasoning for that. It's like, hey, that's really interesting. How did you come to that kind of conclusion around that? I'm really curious. Given that our goal is to help the person that we're working with.
I find that being able to ask that in a curious way and not sound sarcastic or condescending is also a really fine line to walk there. Um, something, yeah.
But without answering the question, we'll never find out. Hey,
Mm.
and so it's one of those things, just acknowledging, hey, we've got two different ideas here. I'm curious about how you came to your idea, and that's sincere as well. And so that curiosity, and that genuine curiosity, not for critique curiosity,
Mm.
not trying to find out so I can critique you.
Mm.
I'm curious about where you came to this because that's something I don't know, kind of
Yeah.
thing.
Yeah.
And that's sincere as well. And so it can come off as critiquing, but if it's genuine, if it's curiosity, if it's patient focused, then a lot of the time it won't come.
Definitely try to hold on to that feeling of being genuine and being curious rather than critiquing or using it to then have more ammo to support your own case, right?
Yeah, and it's the same thing when clients come back and haven't done their exercise program. They're
Yeah.
gonna they're gonna feel like they're gonna get critiqued.
Yeah.
It
Absolutely.
does. But when we're curious, we can't don't just not recognize it because that doesn't give us more information to help them adapt
Mm.
to engage. But to really curiously and validate the experience and to curiously explore that to them, just like we do with patients, you know? And so we can do that with each other as well. And I think when we do it more with each other, that really helps us with the way we do it with our patients.
Hmm. It's a practice and it's a skill, right?
Yep.
And it definitely feels like, Matt, you've had a lot of practice just talking about this kind of stuff as well, because you seem to talk about it incredibly well, and everything you're saying is so incredibly well worded that I wish I could just like grab all of it and just put it into my brain so I could just spurt out these questions and these these conversations that you're having because it sounds so good. And I realize how good it sounds when I then go and try and ask you a question about something and realize that I can't even word a question to you as well as you are answering these about these complicated situations. And it's incredible. Because I guess you've been working in this area for so long now, right?
Yeah, exactly. And I think, well, the question for you guys is, I guess, what challenges do you guys face, I guess, in working with someone with mental health? You know, what do you feel, guys, you don't know, or is this an exercise thing? Is this a knowledge thing? Like, what are the gaps? Because I think
Mm.
as a profession, the more we're aware about where those gaps are, the more we can fill those gaps with support,
Mm.
information,
Mm.
with connection. And that's there as well. And so, where do you guys sit with everything? That's my question.
I personally, I definitely feel like where I get most caught and feel most inept is when I don't feel like I have the next question to ask or the next thing to say after someone says something quite serious or quite profound. And I sit there in silence and go, God, I really feel like I should say something here. And not necessarily that I feel like I need to give some advice, but even just working out how to validate or acknowledge that what they said was um, quite serious or quite personal, and not fully knowing how to word that to that person, and just feeling like I get stuck there in awkwardness, going, "Oh, I really need to acknowledge this, but I don't know how to do it. I don't have the words in my head right now because I'm so deep in this conversation." So it's definitely the communication. It's definitely the communication, the questions, and just the acknowledgements that I can just say with someone. That's where I feel most like I need more upskilling.
Mm. Yeah, that's some common experience
Mm.
across a lot of EPs, physios, people that work in the physical health space. You know, a lot of the time, because we're always thinking, what's next? In a consult, we're always thinking, we're taking information in, we're formulating a plan, kind of thing. But in doing so, sometimes that distracts us from being present in the moment, kind of thing. And when we get detached for a moment, we get too stuck in the thinking part rather than the observing part.
Mm.
Kind of go, hey, that was really impactful for what you just shared. And just acknowledge that's the first step. Is just
Mm.
acknowledge, and we're all going to acknowledge in different ways and have different words and have different ways to go about it. 10 different therapists will acknowledge something 10 different ways, even if they're trained the same way. Like there's so much variety. And I think a lot of the time we think there's this right way to do it.
Mm.
Um, it just doesn't exist.
Mm.
If we're patient focused, if we're, I guess, aware of being aware is good. It's a good thing to be aware, but there is no right way to kind of go about it.
Mm.
Work with the language with what they're using to you, and work there kind of
Mm.
thing there as well. They're giving you the cues. We just work with what they're giving us, and that's sincere as well.
Mm. And so I guess from a without it being a framework, because you can't really have uh, a simple framework for this stuff, but it's all it's always acknowledge first, right? In some way or another, lead with acknowledgement, and then hello, child. That's all right. It's lead with acknowledgement, and then will you try and follow up with another question, or just see what they respond with after you say that?
That silence can go a long way. Sometimes that just acknowledging, giving them space, they might keep going on. Sometimes I feel like we can talk too fast or respond too quickly.
Mm.
And so, yeah, it's again, it's all contextual,
Mm.
and it's all different to, I guess, who we're working with, what we're trying to achieve,
Mm.
and
Mm.
that's there as well.
Mm.
Sorry, I might have to
No,
pause
that's all
there.
right. Andrew, I know you're a big fan of a pause when someone says something impactful.
And I think I do love a lengthy pause. But I think to Matt's point, for us to be very present in those conversations, for like if you catch yourself thinking, what is the next question that I'm going to ask this person? You're not present anymore. You're starting to think a couple of steps ahead. And so like coming back to a very, very like focusedly, that's a new word, focusedly listening to what the person is actually saying. And then once they finish, sort of, if you're not ready to talk yet, if you're not ready to have a question yet, that's okay. You can sit there and just go, oh, wow, like that was a bit. Um, Let me just gather my thoughts on that and then sort of go to the next thing. I think we can kind of we can catch ourselves out when we're trying to think a question or two ahead of the conversation. And what's funny is that people that are quite emotionally intelligent, they can read that in you as well. Like they can read the fact that you're trying to think a couple of steps ahead, and can sort of put a premature halt to a conversation when that happens. That's something that I have had to work very hard on. I know that's been something that's difficult for me to naturally do. Um, but if you're catching yourself and going, "What's the next question?" It's like, no, you come back, come back to the moment.
Mm. Mm.
My experience when I was doing like my psychotherapy training was exactly that. I was always trying to think about what's the next best question I can ask. What's that? The question asked is just going to break down all the barriers. It's going to make things better. It just doesn't happen that way. I think without the connection, without that base in the alliance that you build with people, there is no intervention. And so, especially in this mental health field, where a lot of that's the big thing that is, I guess they feel that it's the barrier to them being and doing the things they need to do. And so right now, a lot of the time, they're not looking for solutions. They're just trying to first feel validated in their experience. And then once we're validated, once we're connected, then we can go, cool, where from here? Because it sounds like there's a lot going on, and it sounds like this stuff is really meaningful to you. How can I support you to engage in those things? And that's sincere as well. And it's perfectly okay. I don't go say, I don't think this is the route. I think this is going to be too much right now based off what you're telling me. Um, you know, a couple of weeks from now, sure, absolutely, different situation. But
Mm.
right now, this is based off what you're telling me and how you're feeling and what's going on around you. This is my recommendation based
Mm.
on and I think sometimes when we verbalize that for them, it makes it a lot more meaningful. To not just give here's your program, off you and you go, but the recognition of how you've responded to what they've told you, and how you've adapted the program, not just on the physical health and the goals, but also their experience in any type of mental health challenges as well.
And like you said before, Matt, like not polarizing people in posing that to them,
Mm.
not just sort of going like and taking your personal perspective on that and going, oh wow, like that sounds like you got too much going on for us to think about exercise right now. You should come back in whatever time period and then we'll be ready to go. But rather like almost phrase it as a question. Like, wow, that sounds like there's a lot going on right now. Are you sure that this is the time right now that you want to add another thing onto the list of things? Because I'm worried that, this might sort of be the straw that break the camel's back. And so you're sort of allowing them to either go, yes, this is what I want right now, or, oh, yeah, no, I think I understand what you're saying. I think I need to sort this other thing before I do this thing. And that way I'll be able to be in a better headspace. Either of those examples is a good outcome.
Yeah. In my mind, there's always something we can do. If we're at 90% full, there's that 5% we can still do. For 50%, there's still that 40, 45% we can still do. It's just we've got to adjust, I guess, how we approach things, but also support that person to adjust their expectations or to just permission sometimes to adapt, to adjust what they're doing. It's what people need sometimes. It's okay to do this. It's okay to, like we all say, it's okay not to feel okay. And it's okay to adjust what we do based on how we feel. But how do we also engage those things that help us feel connected? That often they're a mix, of feelings, right? Sometimes if it's connecting to our family members or our friends, and if we're not feeling down, we don't want to burden them, you know? And so part of connecting is to connect that help also comes with the acceptance. I'm going to also feel like that, uncomfortable in doing so. So the meaningful kind of, I guess, outcomes are always a combination sometimes of the outcomes, but also we have to take that step of being in the uncomfortable nature of this. So then I can do those things. But sometimes we need that support to make that uncomfortable step. And that's okay. There's going to be times for all of our lives that we need that support. And that's there as well. And so a lot of it, I guess, it's almost like we're modeling, or I guess how we adapt exercise, but more about, I guess, how do we adapt behavior in response to what's going on, and being mindful about, I guess, what are we avoiding? What are we pulling away from?
Matt, we're gonna have to get you back on another podcast, mate, because I feel like we're barely scratching like half of the topics that we want to get into. But I am also aware that it's a Monday night, and you both have children. So Matt, before we go, do you have any resources that you've made, or resources that you know exist for EPs or kind of people in the physical therapy area, that'll be helpful for them if they are looking for more information around helping people with mental health?
Don't be afraid to do professional development courses or listen to podcasts from different disciplines.
Mm,
To go do that occupational therapy kind of PD, to go do that psychology PD on trauma-informed care. I think we can learn a lot from different professions,
mm,
and how they practice and how they approach challenging situations.
mm, mm,
And then we can think about, how would that approach look in EP scope?
mm,
And that's there as well. Books. There's a lot of books out there, research wise. Exploring it a lot about often, yes, not what is schizophrenia and what is depression, but the experience of it. I think a lot of uni, we don't put a lot of emphasis on qualitative research.
mm,
We put a lot of it in quantitative research.
mm,
Quantitative research might tell us something is this beneficial, but a qualitative research and exercise and mental health will tell about what people experience.
mm, mm,
Not exercise isn't going to help everyone. An RCT doesn't help everyone.
mm.
There's always people that don't get the same benefits or the same experience out of it. Once I guess we're aware of that variety of experiences, then we can start exploring and communicating in that space.
Wow.
And that's there as well. And so, not everyone has to do a master's in mental health or postgraduate training in that way, but to start those conversations, to go, hey, this is an area that I'm curious about, what someone's experience with their diabetes care. Type 1 diabetes, anxiety go like hand in hand a lot of the time, because it's constant monitoring, constant tracking.
Mm,
That feeds anxiety kind of
mm,
thing. So it's not just mental health disorders, but it's more about, I guess, how we explore the experience of a certain physical health challenge. Pain is a big one.
yeah, absolutely.
And so I think capture what you're already doing. Capture again, rather than just thinking you don't. That's not translatable. It is translatable,
Mm, mm.
but we're working off the person's experience a lot of the time. And then
Nice.
if you feel like there's knowledge gaps, there's a lot of information out there. It's connecting out, fellow EPs or fellow different clinicians that work in the area, or if it's going off to do research, to read a book, to do a BD course, to listen to another podcast, whatever that might be.
Mm.
It's more of an outcome of your curiosity.
Mm.
And that's the important thing.
And Matt, if people want to reach out to you and ask you a question, what's the best way for them to do that?
I don't post much on Instagram, but my Instagram page has had 3 names in the last few years. So the Mind and Body feed currently on Instagram is fine. I don't check LinkedIn much. And so it's probably the easiest kind of way to people to reach out and have a chat. And again, I'm always open to have a chat. I supported a lot of, I guess, new clinicians, less experienced clinicians, both in private and public land. I love putting my time towards that because people did that for me. And so it's kind of like that pay it forward kind of way. And so I always, take my time, put time aside for those kind of things.
Great. Well, we'll have you back on, man. We'll talk more and we'll organize another time because I feel like we have more questions and other people have more questions that we can talk about as well. So thank you so much for coming on, man. We really appreciate you.
Appreciate the opportunity and thanks for a good yarn. So.
Oh, great yarn, mate. All right. Well, we better leave everyone to it. So goodbye, everyone. Thanks for listening.